So my name's Dr. Steve Munday. I'm the County Public Health Officer. I've been in this job for a while, and some of you who have been around for a while probably remember some kind of similar things that happened back in 2009 when we had the H1N1. The difference there was, in case those of you who are younger don't remember this, is that we had the very first case here. So we were basically ground zero for that outbreak. This is a little different because it obviously happened on the other side of the world, but what it proves is that infectious diseases do not respect borders. And we have certainly discovered that. So what I'm going to do is just quickly go through some things with regard to coronavirus, just so you guys kind of know some basic science and whatever, compare it to some of the other coronaviruses that have been out there. But what I'm really going to do is get through this material fairly quickly and then give you guys the chance to ask me questions, because I know there's going to be a lot of questions with regard to infection control and what we're going to be recommending in terms of processes and whatever, and I really want to be able to spend as much time as you guys need for me on that. So by the way, just so you know, the picture here, the reason these things are called coronaviruses is corona is the Latin word for crown, and they've got these things that look like crowns on them, so that's where the name came from. It's your typical RNA virus. It is actually an enveloped virus, and for those of you who know what that means, it means it's got a little coating around it. But this is a new one, hence why they call it novel coronavirus, because it's new and therefore there's no immunity in the population. So I'm not going to spend time talking about MERS or SARS, but just understand that this is not the first coronavirus to jump from animals to people and to cause an outbreak. However, what's unprecedented about this one is just the size of the outbreak. We are very soon going to hit 100,000 cases. Obviously, that dwarfs our prior outbreaks. Fortunately, at least so far, the case fatality rate appears to be lower with the SARS-2. And just so you know, they did change the name. COVID-19 is actually the name of the disease for coronavirus disease, obviously discovered in 2019. But the actual name of the virus is actually SARS coronavirus 2. So I'm just telling you that, so if you see that out there, that's what they're talking about. So this is a zoonotic disease. What that means is it started in an animal and it jumped to people. And you guys have heard this talked about before in terms of flu, for example, avian influenza, or if you remember what we originally called the pandemic H1N1 back in 2009, we called it swine flu. And that's because they discovered that at least parts of it had started in swine and then intermingled and then jumped to people. But that's what a zoonotic disease is, that it starts in animals and then jumps to people. Sometimes we continue to share them. Sometimes it changes and then it only goes to that one particular host. So the fact that this one's now in people, it may or may not jump back to animals. I have seen some data that suggests that other animals could potentially be infected. Unfortunately, this has led to some bad things being done to some animals around the world. I hate to hear that, but we don't really know exactly what other types of animals could potentially be infected. This probably started in bats. That's what the prior coronaviruses did, and then may have jumped to another intermediate host before it came with people. We haven't gotten all of that worked out yet. We'll probably figure that out over the next couple of months. So the reason that a novel virus is a concern, whether it's coronavirus or a pandemic flu, is because there's not immunity in the public, and therefore there's more risk of it spreading widespread and there being more severe disease. There's nothing specific about this coronavirus. This could be any virus, including, like I was talking about earlier, like an avian flu. This is already old data. As of today, there have already been more than 90,000 cases reported. As I said, we're very soon going to hit 100,000. We are over 3,000 deaths. Roughly 175 of those have been outside of China, so China is still getting the brunt of this. As I'm sure you guys are aware and concerned, probably why you're all sitting here listening to me, you've heard about what's going on in Washington State right now, that there's been an outbreak in a nursing home and there have been at least 6 deaths. That's the last I heard. I don't know if they've updated the numbers since this morning, but those are the first deaths in the United States, and we now know that there's healthcare transmission that's happened in the United States as well. Obviously, community transmission was reported roughly a week or so ago. So just some information with regard to the infectiousness. So the R0, which is the term that we use to say what's the average number of people that a case infects. So if I have this virus, how many people on average am I going to pass this on to? That's what's called R0. And the estimate's between about 2 and 4 for SARS. For flu, it's about between 1.5 and 2. Obviously, it varies by season. And so far, the estimate that we have for COVID-19 is between about 2.5 and 4. This number will change. It will vary by location and other things, but it gives us an idea that this is potentially a pretty infectious agent, because it could potentially mean that each person who has it can infect 2.5, 3, or 4 other people. Obviously, that means more exponential spread. And that may be in part why we are seeing this now at much higher levels than these prior coronaviruses that came out. What's the incubation period? What they did initially was they used the outside edge of the incubation period for other coronaviruses like SARS and MERS, and they picked 14 days, and that was just to make sure there was a safety factor built. But as we collect data, what we're seeing is that it's typically around 5 or 6 days, and that's probably was true for those viruses as well. But again, we always want to add a safety factor while we're collecting data. So around 5 days. And what's typical, and I'm not going to go through the specifics of the graphs, but you kind of see what we call a positive skew on a curve, meaning the majority of the cases are here, but there's always a few cases on the outside edge. But we feel really comfortable by using a 14-day incubation period that we're unlikely to miss anybody who's potentially infectious. And this was similar to SARS. In terms of severity, the case fatality rate in China has varied between about 2% and 4%. If you look at the data from outside of China, it's probably not quite as robust, because there's fewer cases and the collections probably vary, but it looks like it's on the lower end of that. I personally believe that as we get more and more data, and as we do more testing, and as we test people who are either asymptomatic that were exposed or have very minimal symptoms, and we're just looking to see how much of it's out there, these numbers are going to go down. But we don't know by how much. Just as a comparison, if you look at flu, the case fatality rate varies between about 0.1 and 0.2% from year to year, meaning between about 1 and 2 per thousand people who contract influenza die from it. So this is higher than that, but again, because we are skewed toward the more severe cases, because those come to our attention, it's very likely this data will change, hopefully meaning that it will go down and not up. In terms of severity, if you look at the averages, about 80% of cases are very mild or mild, maybe even asymptomatic. Again, I think it would be higher than that if we really looked for people who got exposed and didn't develop symptoms. But even not taking that into account, it's about 80%. About 15% have what we would consider severe disease, defined as needing to be hospitalized. And then the ones who are really severe, typically it's around 5%, and that might be the person that ends up in the ICU. And as I said, roughly 2-3% or so of those people will die. A lot of the people who got more severely ill were the typical kinds of things we would see with flu: older age, immunosuppressed, concurrent health conditions. What is interesting so far, and we don't know what to make of this yet because it might be a data collection issue, is the effect on kids. I think everybody in this room probably is aware of the fact that when we talk about people who are at risk for severe complications of flu, we talk about both ends of life, basically our senior population and our children, particularly our infants. So far, this has been a very limited problem in children, but again, some of that may just have to do with the data collection. I just thought this graph looked really cool. That's kind of why I threw it up there, but it sort of puts a lot of information in one graph. The way to look at this is that as you go to the right, that means the disease will spread faster because you infect more people. Notice measles is way out there. We all know how infectious measles is, and obviously we've recently been dealing with a measles outbreak as well. And then as it goes up, then that's your case fatality rate, meaning the higher up, the more likely somebody is to die who has the case. So just to give you an idea, at least so far, where Wuhan falls, again, giving an average case fatality rate of about 3%, and the transmission, they use it as a box between about 1.5 and 3.5. So how do these people present? Well, it's our influenza-like illness that we all are so familiar with at this time of the year. Basically, they come in with fever and respiratory complaints, which they typically have described as cough or shortness of breath. For flu, the definition we use is cough or sore throat. Obviously, if they were short of breath, we could use that as well. But the typical sort of outpatient description we use in determination about when to test, we tend to use those symptoms. GI symptoms are occasionally reported. That's not surprising. Somebody gets a lower lobe pneumonia. One of the things they teach in medical school is if somebody has vomiting or abdominal pain, maybe they have pneumonia. So it's not shocking that there could be some GI complaints. And we do know that this virus can be shed in like the stool as an example. So it is certainly possible that it could cause some GI disease, but it's not a prominent feature. We do know that there are confirmed cases that don't have any symptoms, and we do know that asymptomatic transmission can occur. That has absolutely been reported. We don't know how much or how often, and we will learn more about that as we continue to do broader and broader testing, where we're looking at people with very mild, if any, symptoms, and also the contacts of such people. As this test becomes commercially available, I think we'll get a lot more information that will answer these questions that are sometimes difficult to tease out. This is an example. I'm not going to go through the details of it, but this was reported in the in the New England Journal of Medicine, in which they described asymptomatic transmission. And they were able to get detailed epidemiologic histories on these people, and that's how they were able to figure this out. Viremia absolutely does occur, and the virus can affect multiple parts of the body and be in multiple different types of body fluids. We do know that the nasopharyngeal PCR could remain positive for at least 12 days. This just shows a case where they sort of did serial testing and noticed that at day 4, day 7, day 11, and day 12, the nasopharyngeal swab was positive. However, on day 12, the oropharyngeal swab was negative. Now, that could just be lab error, whatever. I mean, it seems weird to me that you go 2 inches apart and you get a positive specimen in one and a negative in the other. So I frankly think that's just probably random variation or lab error. But as we'll talk about, this is why they recommend that we collect swabs both from the naso and the oropharynx in parallel and submit them separately. So who's getting tested? In other words, what sort of our epidemiologic definition? I'm sure you guys are aware of the fact that this has changed over time. Basically, anybody who has fever or respiratory symptoms who is what we would consider high risk, meaning somebody that we know was exposed and didn't use appropriate PPE, that's important as well, then that's the highest risk, and those we want to test them. Again, fever without respiratory symptoms or respiratory symptoms without fever. The sort of typical thing that we think about are the ones who have fever and respiratory symptoms. Again, cough or shortness of breath, and a history of travel from an affected geographic area. Originally, that was China, in particular Wuhan, but as I think you guys know and we'll see in a minute, they've added additional locations, and those likely will change as well as countries continue to have outbreaks and the cases expand. What we're now doing, especially now that the testing has become more available, again, I'm going to talk some more about that in a few minutes, is that we are looking at people who have fever with severe symptoms, i.e. these people who come in during flu season that have fever and probably have pneumonia or whatever because they're short of breath. We admit them to the hospital. We're now looking at testing them, and we now actually are starting to test those kinds of patients. I'm already getting calls about these and whatever. And we do have the capacity now to test those kinds of patients, and will test them. The current affected geographic areas are these countries that I listed, but this really changes on a day-to-day basis, and you just need to look at the CDC website to see what the current recommendations are, because it's going to change. So this is already out of date. In the United States now, we probably have about 60 cases, including the repatriation cases as well. As you know, we've had 6 deaths. We have confirmed community transmission in multiple states now. And we know that healthcare transmission has occurred. So that's why we're doing this, because although we have not had a case yet in Imperial County, we are going to get one, and we want to be at the front of this, not the back of it. So how do you stop an outbreak? This is from Dr. Fauci, who I'm sure most of you guys know from the National Institutes of Health. Essentially, you do surveillance, good contact tracing, and good case identification. The great thing is we have some very skilled people in this room, both from my department but also here as well, who know how to do this and have been doing it for a long time. There's nothing magical about this disease. It's shoe leather epidemiology. So containment versus mitigation. Isolate the sick, quarantine the exposed, just as a public health person, as an epidemiologist, just to remind people the difference. Isolation means to segregate someone who is sick. Quarantine means to segregate somebody who's been exposed, but who isn't sick, but we're afraid might expose other people. That's the difference between isolation and quarantine. People tend to use them interchangeably, but I think it's important for us here to understand the difference, because it certainly may have important ramifications when we're making decisions about what we're doing with people. Obviously, we do social mixing. I will tell you that over the weekend, I was on a very interesting call with my fellow Wizard health officers around the state, with the state health department, and a very large part of that discussion centered around schools and also social distancing and large gathering. We are approaching spring very rapidly. It's starting to warm up. We all know that things are going to be happening. There's going to be large gatherings of people. And the question is, what should we do about that? And a clear, cogent strategy has not yet emerged, but it has been being actively worked on. It's not shocking that it hasn't emerged yet, since when you look into this, this is a rapidly changing situation, and we are trying our best to respond as things change. So the things that we can do, obviously deal with the hospitals and healthcare facilities, hence why I'm here. Restrict transit. Obviously, they've already been doing this in terms of airlines or whatever, but it could be broader based if necessary. And then they start looking at like closing things, either voluntarily or ultimately, if it were bad enough, of course, they could consider making this mandatory. And then public events. Again, these are all common sense. And I'm just merely listing what the tools are, not whether we actually are currently doing them. Some of these we are, some of them we might do later. It really just depends on how this continues to go. So in the United States, the control measures, I think everybody's aware that we have travel notices. This is updated as of this morning. Level 3 means don't go. It's all non-essential travel, do not go. Level 2 means if you are a high-risk person, let's say you're an elderly person or person who's immunosuppressed, it's probably not a good idea for you to go, because if you get exposed, you might get sick. And level 1 basically means that you don't have, that anybody can go, but maybe just pay attention to what's going around you, because things might change. I think you guys are aware that they're doing screening at airports, particularly flights from China, but this screening process is being looked into and revised all the time, and as the risks change, this screening process will change as well. We already sort of talked about isolation and quarantine. Here in California, obviously we had that, those persons who were repatriated back to the United States. Keep in mind the difference between isolation and quarantine. They were quarantined until they became sick, at which time they were isolated. It's merely a semantics, but I think it is an important distinction. And then, of course, contact tracing. And again, shoe leather epidemiology. When you only have a few cases, that's not so bad, but as this thing starts to spread, obviously we get overwhelmed and it becomes harder and harder to do this. I'm not going to spend any time talking about this. Again, we know about these people who are quarantined. Contact tracing, I kind of talked about this a little bit. This is what the epidemiologists do. So exposure risk, this is what's off of the CDC website. I'm not going to spend a lot of time talking about it, but they look at it in sort of different fashions. One, the highest risk travel. Hubei is still the highest risk for sure, but other places are pretty high risk now. And then somebody who has intimate contact with a known case, either because they live with them, they are their intimate partner, or they are a healthcare worker who's taking care of them, who doesn't use appropriate PPE. That's the highest risk. Medium risk would be people who travel from other places outside of Hubei. That would include now places like Italy, Iran, not likely going to have many travelers from there, or people who have close contacts, as I described previously, but who do use appropriate PPE. And then finally, if you're in an aircraft. Basically, the way it works on the aircraft for this kind of a thing is that if you're within 2 seats of a case, then that puts you at high risk. If you are within 2 rows but outside of the 2-seat range, then they use medium risk. And that's really what they kind of do for droplet spread in general. Airborne obviously can be a little different from that. Again, I'm going to talk about that more in a minute. And there's kind of what it looks like. So if you're within 2 seats of each direction, then you are considered to be the medium risk. If you are farther away, i.e. within 2 rows, then you're low risk but not 0 risk. So you get away from the 2 rows and no identifiable risk. And again, this is what's typical for droplet spread. And then low risk is somebody who's sort of been in the same general environment for a prolonged period of time. They don't define prolonged period of time very well. They kind of leave it to common sense. I will tell you that people are typically using things of like 10 minutes or whatever. That's kind of what is out there if you ask various different people what they're doing. But there's not if you read the CDC guidance, it really just kind of says, oh, you have to decide based on how intense the exposure is and whatever. They don't give you, if it's X number of minutes, that's considered to be a prolonged period of time. So severity, we talked about this already. I'm not going to spend a lot of time here. The bottom line is, like most icebergs, which are below water, the asymptomatic cases are going to be true for this as well. And we will not really know exactly how big that is until we finish collecting the data. I already talked a little bit about this, but to give you an idea of just the risk of infection or contagiousness, we can see that measles is really at the far end there. SARS is kind of in the middle. And this one, the R naught, is similar to SARS, so it's probably in that same general range. A lot of things determine infectiousness. Agent factors, meaning the virus itself, how contagious it is, but host factors as well, whether or not somebody is immunosuppressed or whatever. All these things make a difference. Again, that's not the brunt of this talk. I'm not going to spend really a lot of time talking about that. And then I would just mention herd immunity, because we talked about it a little before. Obviously, something like flu that's already widely circulating, there's some immunity to that. Even when a newer strain comes out, there's probably still some partial immunity. But for something like this that's a new virus, we don't really have that, and therefore it makes it more susceptible to spread. Super spreaders is that there are some people who perhaps because their immune system can't contain the virus and they have very high levels, they might be what we would call a super spreader, which means even though the average risk of somebody infecting some other people is between 2-ish or 3 people, a super spreader might be somebody who's shed so much virus that they really infect a lot of people around them. And so that's always a concern in diseases like this, that you have a couple of people who do a lot of transmission and therefore infect a lot of other people. And that does actually happen. So I think you guys all know this all started in Wuhan. There's 11 million people there. It's a major transportation hub. The earliest hospitalized case was reported December 1st. They actually reported this disease to the WHO on New Year's Eve. They believe a wet market was a likely source, and that's just because of the animals there, which allowed this to jump from animals to people. Of the initial case series, the majority of them did have some kind of contact to the market. The size of the circle just tells you, how many cases. I'm not going to spend any time talking about this. Just wanted to show it to you graphically. There's China again. Lots of stuff going on just to kind of show you where everything is. There was a discussion a couple days ago about the fact that maybe the cases in Wuhan were starting to decline, but then it probably turned out that was just some reporting error or just some random variation, so we'll see what happens. And then you guys are probably aware of the fact that they did actually attempt to quarantine the people around Wuhan. And a lot of this had to do with the fact that it was the big New Year celebration and tons of people were going there. Again, I'm not going to spend any time talking about this, but it was the perfect storm of things. It's winter. There's already respiratory illness that's going around. There's tons of people in China already. Now all these people are moving around. Some people get infected, probably a few super spreaders infected some other people, and then they started traveling around. That's kind of the scenario of how this probably happened. Here in the United States, by the end of January, we had already declared a national public health emergency, and a lot of stuff has been going on. You guys probably are aware of the press conference that went up last week, in which the vice president was touted as now he's going to be heading the task force that's taking care of this problem. And state and local health departments are already responding to this. And I just want to make it clear to you guys, despite all the politics and whatever that you hear about, the public health community has been avidly working on this for many, many weeks now. And just because you haven't heard about it does not mean that it has not been taking place. So you guys are aware of the travel advisories. This is actually one from the State Department. They have a little different system than the CDC does. They have a 4. The CDC just goes through 3. But the bottom line is that if you're a 4, you're not supposed to go there. And then, just so you're aware, there was a law enacted in 1944 that FDR signed that gave the Public Health Service broad powers to try to prevent disease entry into the United States. And so it allows for a lot of things to take place at the federal level, and that's exactly what's been going on. Again, a lot of it behind the scenes, so even though you haven't been aware of it, it still actually has been happening. So we already talked about quarantine a little bit. They made a big deal about this whole quarantine thing, but honestly, on a smaller scale, we in public health use quarantine and isolation all of the time. Here in Imperial, I probably don't have to tell this group this, but we unfortunately have the largest proportion of TB cases relative to our population in the state. TB is clearly infectious. We have to deal with people trying to cross the border. So we are regularly dealing with this particular kind of an issue. And then ports of entry. The main thing was, of course, focused on the airports, but you should know that screening is taking place at other ports of entry, such as the border crossings, as well as the ports. Masking, it's a big thing to do in Asia. I've been to Asia many times, and you see lots and lots of Asians. They just tend to wear masks in general. That, of course, creates a problem when you actually might need them for something, because then suddenly there is a short supply. It is important to know that there is a difference in the effectiveness of the different things that, quote unquote, might be considered a mask. A surgical mask is just a normal mask that the surgeon wears, or that you might use in a healthcare setting because you're doing something and you don't want to get a splash in your mouth or nose or whatever. It doesn't really protect you against aerosols. What it does do is potentially protect a source patient from projecting those aerosols, because you guys have probably all seen those videos that they show you when somebody coughs or sneezes and you see all that stuff that goes in the air. Those are large droplets, and that's what a surgical mask protects against. All of that stuff, rather than going out into the air, gets trapped into the mask. What it doesn't protect against are those small little aerosols that float in the air that you cannot see. So that's what an actual respirator like an N95 is supposed to do. Why is it called an N95? Well, the N stands for not oil resistant or proof. There's actually an N, a P, and an R, and the P and R stand for oil proof or oil resistant. The number has to do with filtration efficiency. So, for example, an N95 by definition filters out 95% of 0.3 micron particles. An N99 filters out 99% of 0.3 micron particles, and an N100, which is equivalent to a HEPA filter, filters out 99.97% of 0.3 micron particles. And the reason they picked the 0.3s is because that's the most penetrating particle. Larger ones and smaller ones actually are less likely to get through the mask. However, what it doesn't tell you is, for example, something like side leakage. In other words, if it comes in the sides, it doesn't go through the mask. And that's why, for example, fit testing is so important, because you want to make sure that the mask is doing what it's supposed to. And that's the whole purpose behind fit testing. You guys all heard about the Diamond Princess. Basically what they did was just trapped a whole bunch of people with a infectious disease that was just spreading like wildfire. It's very unfortunate. A lot of people got sick and 6 people died. But it just proves how contagious this disease can be under the right circumstances. Vaccine development. The sequence for this virus is already publicly available. They've already got governmental and private agencies working on both diagnostic testing and vaccine development, and also looking for drugs that might be available for treatment. And there's already trials taking place. It's pretty amazing how fast all of this happened. So in conclusion, this is a pandemic. They may not have actually called it that yet, but it is. Pandemic basically means you got 2 broad-based geographic regions, like say 2 continents that have an outbreak. We've clearly met that already, even if the politicians don't want to call it that. This is now on every continent except Antarctica has now had cases. We're still waiting to see what the future will bring, both in terms of severity and spread. But in the meantime, there are some things that you can do. The same things that we do recommend every flu season are the same things that you should be doing for this as well. All right, let me stop there and answer questions. Thank you.